today's session. First of all, I hope you and your family are all in good health. And before introducing our speaker, I would like to thank Mrs. Angelica Jacob from BEGO Implant Systems Market Department for the organization of the session today. We had around almost 500 enrollments for this lecture in the period of 1 week, and we thank you very much for your interest. Topic today will be sinus lift and the piezoelectric hydrodynamic technique, and the speaker will be my friend Dr. Gregor Citek from Poland. Dr. Citek is diplomate member of the board of the Polish Society of Implantology since 2012, member of the International Congress of Oral Implantology, active member of the IPA, International Piezoelectric Surgery Academy, and conduct his private implantology clinic training center in Krakow, Poland since 2003. Thanks, Gregor, for accepting the invitation to conducting the session today. As always, at the end of the lecture, we will have a question and answer session, and you can place your question during the whole presentation in the box. You have a question box here at GoToWebinar, and you can place your questions. So I wish us all a very nice time, and I give you the word, Gregor. I'm gonna pull your audio in a second, because just a second here. So Gregor, now you have the audio, sorry.
Okay. Thank you, Marcio. Thank you for introducing me. It's a great honor for me to conduct this workshop, this lecture, this webinar for you. I hope all of you are fine, especially in those very hard times because of the pandemic time in the world. And I hope you will be interested with this webinar, and you will focus more on this technique. Before I start the lecture, I will show you some pictures from the place where I am living. This is Kraków in Poland. Kraków is the second biggest town in Poland. Here on the right side, you see the main square. Kraków has the biggest things in Europe. One is the main square, is the biggest main square, and below you can see the view from the night is the center of the town. Where is a visible, unfortunately I don't have an indicator because we've got problem with the connection. There is a visible the biggest meadow inside of the center of the town. So also I was asked by BEGO to show some pictures from my clinic. This is my reception desk, my room, and you can see in my office the camera which is connected with the flat screen in the conference room, where we can conduct the courses, where you are welcome. Another view. And now we will focus, we will turn to our lecture. Before I will talk about the sinus lift, hydrodynamic sinus lift technique, I will tell you a little bit about the biology and physiology of the bone, of the grafts, and the principles of working of piezo. Because I think without those things you won't be, especially those who are not familiar with this technique, will not understand which material, why we should use this kind of material, and how everything is working. So what is the impact of our graft to the bone? First is osteogenesis, osteoblast ability to create the new bone. Osteoconduction is a graft is a matrix for the new bone which is grown into it, and the blood vessels. And also induction is a synthesis of the new bone under influence of morphogenetic proteins, maybe mainly BMP2. All of those abilities has the patient's own bone, and that's the truth. We are calling it the golden standard. But from few years, we can say that some of the allogenic, especially gamma irradiated fresh frozen bone block grafts, has the same abilities like the patient's own bone. All those things they have. So this is in the future, but it's a topic for the different lecture, I think. So how the bone is healing. This is also very important. The trauma, it doesn't matter whether it will be elevation of Schneiderian membrane or tooth extraction or placing an implant. Everywhere the healing is the same. So we have first we have a trauma, vascular damage. It causes hypoxia with metabolic supply, and it causes that the environment is getting more acidy, and this causes that the clot is formated. And from the cardiovascular cells, cytokines and growth factors are released. Mainly, the most important is BMP, like I told you before. And this causes the emergence of granulated tissue, blood vessels formation, clot breakdown, and then is the bone formation. And how it looks in the days. This is important. In the first day when we have a trauma, socket or the graft is filled with the blood, with clot. During 1 week, clot is organizing, and we have to remind that after 8 days we have the bone resorption. The bone resorption is starting after 8 days. There is now the question when we should to place our implants. So it means from this that we should to place it as soon as it is possible. So immediate implantation is favorable. If not, we should to do it as soon as possible. After 2 weeks, we have the first hard tissue appears, is a woven bone. Then after 1 month, after 30 days, we have first osteotomes of the lameral bone, but it is still soft tissue called woven bone. After 2-3 months, we still have a woven bone. So we don't have a lameral bone. Lameral bone appears between 120, 180 days. So in fact, we can, from this, we can say that full osteointegration of the implant or the graft we have after half a year. That's why I'm always waiting. It doesn't matter whether it is maxilla or mandible. I am always waiting half a year with implant loading. And same is with biomaterials. It's a mistake if we, for example, place the graft. It doesn't matter if it will be bone block graft or granulated particle material, and we will start to work with this. We will make a re-entry after 1.5 months or 3 months. We should wait about 6 months before we will place our implants. So what can disturb the healing of the bone? First is impaired bleeding. It can be caused by different reasons, mainly from the organism problems like hormones and other things. Lack of primary stability, this is very important both for hard and soft tissue. Size of defect in excess of the critical size. This is very important because we can say that in implantology we've got a kind of rule that we can graft same quantity of material, same volume of material, like we have a recipient bone. So let's say if we have, for example, 3 millimeters of the recipient bone, we can graft 3 millimeters of the bone. If we have 5, we can graft 5. We cannot graft 10 millimeters. Of course, we can graft 10 millimeters, but it's more predictable if we graft the same size like we have of the bone, because otherwise the blood vessels will not get into the graft. So because of this, it happens very often when you speak with the surgeons who likes the lateral approach to the sinus. They are very often complaining that after 1 year, because if you have a huge defect, they are waiting usually 1 year, that after 1 year they have same granulated material like they left 1 year before. Why? Because they excess the critical size of the graft. So we'll come back to this later when I will show you the lateral approach. And then, of course, which is very important, emulation with the tissues of high capacity of proliferation. So it means that we have to use always think about use the membrane material. And of course, we can be aware which kind of membrane we will use to different kind of grafting material. I have divided into 3 groups biomaterials, and I divided in them of the speed for the speed of resorption. The fastest resorption material is a human bone. Of course, the time of resorption can vary. It depends from the size, from the quantity of the cortical layer of the bone. The more cortical layer of the bone we have, the time of resorption is faster. So resorption can be from 4 to 12 months. Bovine material is about the slowest material for the resorption, and after 7 years, we still, from the researches we know, after 7 years, 33% of the material is still the bovine, not the patient's bone. And we can have it in particle materials or bone blocks. Bone blocks as a xenograft, you should to be very, very careful with this material because they are not predictable. Not more than 30% of the bone blocks works. Why it happens? Because it's a different structure of the bone. That is why, for example, BEGO now will have a new biomaterial. I don't know if they will release the bone blocks to the market, but they have a different kind of thinking about the biomaterial. The particles of the materials, every particle of the material is treated to have the similar structure to the human bone, and every particle of the material is coated with, we can say, is coated with collagen, and from those particle material they can produce the bone blocks. So this xenograft probably in the future will be the answer. Will be we can with this replace the human bone, but we will see. And the last group is the synthetic materials. Mainly, it's a mixture of 60% of hydroxyapatite and 40% of beta TCP. The medium time of resorption 2 and 3 years. But like many clinicians, I am very careful with using synthetic materials. Mainly, I can say I'm not using them because this mixture, in some cases, can cause the inflammation with which we cannot deal with. So we have to be very careful with using synthetic materials. So the bovine material, because of osteoclastic influence of the Schneiderian membrane, is a favorable material for sinus lift. Of course, there are some researches, like in Israel, there were researches on the university. I don't remember, probably, I think it was in Tel Aviv, that they were elevating Schneiderian membrane. They were placing in implants and with no adding any augmentation material. And after this, they realized that they have a bone between the implants and the Schneiderian membrane. It happened because there was the blood, and Schneiderian membrane was elevated by the implant. This is also very important, which size of particle material we will use. I will show you later the case where I've used the bovine material with nanoparticle material, which was not visible in the X-ray, and in most part of the cases, after half a year, you don't have nothing, because with a small particle material, you will not have a bone, because it will not keep the volume. So it must. So concluding to the sinus, we should use, because of the osteoclastic effect of the membrane, we should use long time resolvable material, and with small or medium size particle material. That would be favorable for the long-term success. This is the research that proves that that bovine material, it has a long-time resorption, like I told you before. There's another picture from my hometown, from Krakow, from the main square. This is Mariacki Church. And now we will turn back to the piezo. So a little bit of history. So first publishing about piezoelectric device surgery was in 1960. In 1998, Torella and others, they published the first case report about lateral window approach performed with use of piezoelectric scaler. I think because the power of the scaler is not so high, so I think this surgery took a long time. And 1 year later, Tommaso Vercellotti, one of my friends, he shown the first piezoelectric device for bone surgery. And 1 year later, he published first case report from bone splitting made with piezo surgery. Piezo surgery is a trademark for company of Mectron, so we can use only piezoelectric surgery term. Okay, what it is? Definition of piezoelectric surgery is a surgical method based on the use of microvibration created by a medical handpiece and generated by a specifically designed medical device that exploits the synergy, micrometric cutting, high precision bone cutting, and selective cutting conservation of the soft tissue. So this is the definition, but concluding this, it means that we have a device which is like here on the picture. Then we have a handpiece. In handpiece, we have ceramic discs which are using the piezoelectric phenomenon, which I will explain you a little bit later. And because of this phenomenon, there are vibrations which are by the converter turns to vibrations of the working tip. So there are different kind of devices on the market. I've took the most powerful devices on the market. One is the Acton piezotome with the frequency of working tip is around between 28 kilohertz to 36 kilohertz with the still oscillating frequency. And those two, Mectron and Esacron, they have between 22 to 30 kilohertz, mainly Esacron, with a force oscillating modulation. Due to this tip has two oscillation in different directions. This gives you faster working, and of course, the more powerful device, the faster it's working. So devices are having the power from 15 watts to 70 watts, like if, in case of the strongest device of Esachrome, which is between 50 to 70. Mectron has an Acton around 30. Principle of operation, like I mentioned you before about the phenomenon of the piezoelectricity, the materials which exhibits this phenomenon are crystal quartz and ceramic discs. Nowadays, we are using ceramic discs for in the devices. And how it works, it means that the alternative current induces the alternating expansion and compression, which through the converter changed into the micro movements vibrations of the surgical tip. So it's like this. We have a piezo unit, the handpiece, and the tip, which is working. So in fact, many doctors which I have faced, they were I was discussing. They were asking, so there are some ultrasounds that are cutting? No, there are no ultrasounds. Of course, they are, and they are very important because the ultrasounds are responsible for the cavitation effect, for about which I will mention you later. But the working is by vibrations. So this 30 kilohertz, it means that we have 30,000 vibrations per second. But because the tip is vibrating, it is swinging from up and down, the left, right, it turns to over 1 million, around 1,800,000 revs per minute. So this is very fast. That's why this tip must be very hard and is breaking quite easily in every device. So we have a precision of working because the scope of vibrations is horizontal blade vibration is 60 to 200 micrometers, and the vertical is 20 to 80 micrometers. So the cut efficiency depends from several things. One is how we are working. So from the vertical force which we are pushing the tip to the bone, and with the slide movement. If we are pushing with not sufficient force, then the tip will slide on the surface of the bone, and if we push too much, then we will stop vibration, and also it will not work. And because of this, it also depends from the power of the device. The more powerful device, the stronger we can push the tip. And also it depends from the condition of the tip. So what are advantages of the piezoelectric surgery? First is a little traumatic, high working precision, limited effectiveness to the soft tissue run, because we don't have rotating bits, and because the tip is very, very small, we can cool it very easily. So we don't have if we use enough cooling saline solution, we will not have overheating, so we have a lack of necrosis. We have a very little bleeding because we have a saline solution. We have a cavitation effect, which has a very strong activity and antibacterial activity, which is releasing free oxygen, which is having anti-inflammation activity. Thanks to this, we can even work in contaminated area. We have a safety because we have no risk for surrounding tissues because we have no rotating bits. Duration of the surgery with the new devices is not longer than with traditional techniques, traditional devices, surgical devices. Because we don't have overheating, we have a more growth factor releasing, and very little or no pain and very little or no swelling after surgery. It was proved by the Kripa and others, by the researchers. And from my clinical experience after over 10 years of working with piezo, I can agree with this. So cavitation effects, it's like a detergent effect also. It's because Ultrasound accelerates the insert due to this vibration, generates a succession of pressure and depression phases of liquid. It changes from the liquid, so it changes from the liquid to the gaseous state. So microblades can containing steam, and this is where causes the antibacterial and anti-inflammation effect. So there are some the bubbles in the coolant solution. They are exploding and imploding. So this is here is the difference between explosions. Phenomenon occurs because the internal pressure is greater than external, and the phenomenon of the implosion is a different external pressure is higher than internal pressure. How it happened? If we put some energy to the liquid, like for example boiling water, like here you have on the picture, it doesn't matter if we will put the heat or we will do it by vibrations. Then the heat is because the particles of water are tearing around, tearing with themselves. Then the temperature is a little bit increasing. So we are having the bubbles. The bubbles are are going up, and they are exploding, releasing energy. They're evaporating in the saline. So this is also explanation of implosion, like I told you before. And so the synergy between the ultrasound, you see how on the here on the picture we got the those bubbles are getting bigger and smaller. It's changing, and suddenly they are exploding. So now this is causes the detergent effect, reduction of the bacterial load, and conservation of the healthy tissues. So all of this causes that we have a favorable bone response. We have lack of lamellar bone fragmentation, typical for the surgical bars. Lack of pigmentation caused by the bone overheating, meaning we don't have a bone burn. Because we don't have overheating, we have a presence of alive osteocytes, so the organism can easily turn to the healing. And little quantity of inflammatory cells because we have no overheating, and thanks to this we have twice faster bone regeneration. But if we turn back to this slide when I was showing how the bone is healing in days, we still have to wait half a year. We cannot accelerate so many. Sorry. Okay. And here you have how looks the bone which was cutted by the piezo device in microscope. And this is the difference between osteotomy done by piezo on the left side and the osteotomy done by the drill. So you see the line is smooth and more precise. So for what kind of surgery we can use the piezo, because this is very important, because this device costs a lot, around 5,000 euros or more, or a little bit more. So it will be no use to buy such a device, to own such a device to use only for one surgery. In my clinic, piezo is always ready to use, is prepared to use, and I'm using it every day. I cannot imagine the implantology practice without having a piezo device. When you have a piezo, the tooth extraction is changing. Since the time when I started to use piezo, I'm not doing any kind of extra alveolar extractions. We can use piezo for this to preserve the patient bone, which is saint. We have to be careful very for the patient's bone. So we can use, like I told, for the tooth extraction. impacted molar wisdom tooth. We can use it for bone splitting, for sinus lift, or both for intralift or crestal approach and for lateral window approach. We can use for bone block grafts, for preparing donor sites, for taking out the bone block, for preparing the bone chips. We can use it for preparing the implant site. And for partial extraction therapy, the ESA-Chrome has a special set of tip for a socket shield technique, which I have designed it for them. And this is a very good device for use of this because of the cavitation effect and the antibacterial effect, like I told you before. And I will show you the case of this. And for orthodontics, for corticotomy, which is quite popular, the surgery among orthodontists. This is a view for the main square of Krakow in the evening. One have counted that around this main square and the closing surroundings is about 1,500 restaurants, pubs, bars, and clubs. So this town, it has never sleeps, like in New York. So the socket shields, for example, there's only one case I will show you. The patient came to my clinic with, as you can see here, here on the CBCT scan, with the inflammation of the first incisor. So we decided to extract it. This is a situation after crown removing, post extracting, and there is a root cutting. This is how the root looks. Extraction of the palatal side of palatal part of the root and enlarging the root canal. Implant positioning, implant placement, and you can see same stage surgery, the apicectomy of this part of the root which have left, and augmentation in the same surgery. And this is the final result after the surgery. I think quite successful. Okay, now let's talk about the sinus lift. So, like I told you, we can have two ways to get possibility to get into the sinus. First is lateral approach. I think nowadays is still the most popular way of opening the sinus, of elevating the sinus. And for this technique, we have to use particle material and collagen membrane, which is very expensive, and a crestal approach where we are using only particle material. So in fact, for us as doctors, this is also very important. The cost of the surgery is much lower with the crestal approach. So lateral approach. This case, which you will see now, is a very old case. I think now it's over 10 years, almost 10 years old. I was trying initially in this place, I was trying to elevate the Schneiderian membrane through the crestal approach, but because it was one of the first of my surgeries, just when I was closing to the end of filling the gap between space between the Schneiderian membrane and the sinus floor, I was not so patient. I did not elevate enough the Schneiderian membrane, and when I was adding the last portion of the particle material, I teared the Schneiderian membrane. How did I know that it happened? First, I felt because I get into the sinus. Second thing, because everything in this technique, in the crestal approach, is fulfilled with the saline solution. I saw the bubbles during the Valsalva maneuver that are coming out from the hole, access hole. So the only case of this was to open the sinus from the lateral approach. And this is this thing. This picture shows that the explanations by the surgeons who prefer the lateral approach, they are saying that this is more predictable because they can see if there's a rupture or not, is not true, because here you can see there is a Schneiderian membrane. Another picture, Schneiderian membrane is moving because patient is breathing, and we don't see the rupture. I knew it because there was there were bubbles coming out from the hole of crestal approach. So from my point of view, the first disadvantage of the lateral approach is that is not predictable. We don't see everything. This is the first thing. Second thing, it happens very often that we excess the critical size of the graft, and you will see it later in the researches done by my friend Professor Stacchi. I will show you later. And this is the picture after the surgery and the screws of the bone block grafting. Another picture of my town, the main square. And advantages of the crestal approach sinus lift. First, we have a low traumatic surgery because we don't have to elevate the flap. We don't have to such a size flap. We don't have to cut out a huge window on the lateral wall of the sinus. We can do all the surgery through the tiny hole with the diameter around 3 millimeters. So it's for patients is much less stressful and much less morbidity after the surgery. And because the surgery is less traumatic and less aggressive, is more, in my opinion, is more predictable for the success. Less complications we can have with this kind of technique. Low risk of Schneiderian membrane perforation. Yes, that is true. And in some cases, but it depends from the technique which we are using. If we use conventional summer technique with osteotomy, it's a risk of Schneiderian membrane perforation. If we use devices with rotating drills, the risk of perforation is getting higher. With Acteon's intralift technique, the risk is higher, but I don't say that intralift is a bad technique. It's a fantastic technique designed by the Professor Wainwright, but I think there are also other techniques about where we mentioned that we are not touching Schneiderian membrane at all during the whole surgery. Another thing is a low risk of hemorrhage because there is no possibility to damage arteria alveoli superior posterior. Once I was told after one of my lectures that from one of the surgeons, he mentioned that is not true. This arteria never caused any problems. I have to agree with him, but there are some cases, and we know from the researches of Professor Kim from Seoul that this arteria can get with the size even to 4 millimeters of the diameter. And I've heard, I'm telling you that I've heard only about one case that a very good craniofacial surgeon during the lateral approach sinus lift, he broke this arteria, and he had a very huge problem with stopping the hemorrhage. So this happened probably for some million of cases, but it can happen. So I am admitting about it only. Ability to elevate the membrane at significant loss of alveolar bone height with the height. Here I wrote around 2 millimeters, but now after years of experience, I have to say that we are able to elevate Schneiderian membrane from 0.3, 0.4 height of the residual bone. And because we have a blood supply from all the walls, we can during one surgery to elevate to even 15 millimeters. That's another thing. The blood supply. We got to always think about this. And as we know from the researches, also from Professor Stacchi, Schneiderian membrane does not have any influence for the graft except osteoclastic influence. A few years ago, 3 years ago, when I was lecturing about the sinus lift, I was always telling that the blood supply, the vessels are getting into the graft from the bone walls of the sinus and from the Schneiderian membrane. Now, from the histologic researches, we know that the blood vessels are coming into the graft only from the bone walls of the sinus. So we can, in this case, I think we can consider, from these researches, we can consider that cutting out the window maybe will be in the future considered as a mistake. And the crystal approach will be favorable technique of the sinus lift. And the last thing, temporary sinusitis is not the contraindication like with the lateral approach for the surgery. I have faced with the cases where there was very little temporary sinusitis before the surgery, and after the surgery for the few hours the sinusitis was a little bit higher, and after around 48 hours after surgery, sinusitis was completely gone, because the effect of cavitation, it was the effect of cavitation effect. So this is those researches that I've mentioned, done by my friends, Professor Claudio Stacchi from University in Trieste and Dr. Teresa Lombardi, they and others. They have done researches about bone formation and how it and what is the influence of the size dimensions of the sinus. So they divided the sinuses for 3 groups. On the height of 10 millimeters, there was a group of the sinus which was lower than 12 millimeters. Second group was 12 to 15 millimeters, and the last was over 15 millimeters. And they've done the sinus lift through the crystal approach. And after half a year, when they were placing the implants, the histological researches have been done, and from those researches we know that that the bone was formed. The biggest new bone formation was in the most narrow group of sinus, and so it means that the wider sinus is, the lower bone formation is created. If we have so from this we can know also that if we cut out the window and we have a wide sinus, then we can expect that after half a year or 1 year we will still have particle materials inside the sinus. So we will have a problem. Another research about this histological and histomorphometric study done by Marcel Wainwright, the inventor of intralift technique. Similar results, and review for hydrodynamic ultrasonic maxillary sinus lift, which also proves that this technique should be think as a more favorable technique. These tips which you can see now are the tips of intralift technique for Action. They are using 5 tips, and technique looks like this: that we are passing through the cortical layer of the sinus floor, and in this case we are risking because we are touching Schneiderian membrane. a little bit. Then we are enlarging the axis, and then we are using the tip called trumpet, with which we are pouring the saline solution into the sinus, and because of the vibrations and increasing of the pressure inside, we are elevating the Schneiderian membrane. But like I told you, we are touching the Schneiderian membrane, so it's a little bit risky. So I've designed for one of the producer, I will, if you allowed me, I will not mention of the name of this company. I've designed for them this first tip for the sinus lift. This tip is elevating Schneiderian membrane without touching it at all, because when we are crossing we are passing the crystal floor, the crystal layer of the floor, Schneiderian membrane is elevating at once. Just when we have very small tiny hole in the bone, the saline solution is getting into the sinus and elevating the Schneiderian membrane. So we are not touching it, so it's more safe. And now I am also working with the Esacrom company to design a new version of this tip to be even more safe than this one and to work faster. So I'll show you the case. We'll turn back to the cases. So here is the first case. You can see here it was about 8 millimeters of the residual bone, and you can see the septum inside the sinus. It's a nightmare for the implantologist. In this case, we should access with two from the if you would access to the sinus from the lateral approach, we should cut out two windows on the left and right side of the septum and elevate from both sides the membrane. But on the left side, we have a vital molar, and there is a risk that if we do it, we can destroy the nerve of the tooth. So through the implant beds, I've accessed the sinus. Here are the implants after, and this is the picture after the surgery. So you can see that this technique very easily can deal with the septum without risking of perforation, and the prosthetic work after next year. Case number 2, the sinus lift on the left side. You can see the CBCT scan. The canine was just before the surgery was endodontically treated. You can see there is a small, tiny, sinusitis because the patient she was finishing cold. We don't have a lot of bone. There's the flap and the bone. Here you can see the access to the sinus. Then the collagen sponge was added before inserting the particle material. I've used the collagen sponge to be a kind of bed to protect the Schneiderian membrane from the sharp particle material. And this is the end of the surgery. And you can see the effect just after the surgery. The last molar was kept to support the temporary prosthetic work. It was extracted after the implant placement. And after half a year after placing the implants, you can see how much bone we've created. Case number 3, also not enough bone, and this is a kind of mistake I have done. I've told you when I was talking about the biomaterials, I've used nanoparticle material. So I've elevated the Schneiderian membrane. This is the surgery. That's how it's working. You see the access to the sinus, the collagen sponge. the BEGO implants. It's also very important when you are placing the implants in augmented area to use implants with the surface SLA but hot etched. It's very important because this implants with this surface has higher porosity than the implants which are cold etched. And from the research is done by Professor Curie, we know that the difference in his hands is not so high because it's about 3%. From my experience, I'm not such a great surgeon like him. I'm not a professor, so from my experience, the difference between hot and cold etched implants in augmented area is around 50%. So better use implants with hot edge surface. And here is the X-ray after the surgery. You cannot see the material. And in most part of the cases, we can expect that in half a year, we will not have a bone because nanoparticle material will not keep the volume. Case number 4, another case. You can see here we have around on the left side in the middle line, we can see that we have around 3 millimeters bone of height of the bone. So this is the picture before. Another side, left and right side before the surgery. This is the access to the sinus. Here on this side. Gamma irradiated fresh probes and bone block grafting was done. Another block, because to create the alveolar to the width to place the implants. And after 6 months, you can see how much bone we have. On the place of 1/4 tooth, we have 14 millimeter to the height, 9.3 millimeter to the width. And the other side, we have almost 10 millimeter to the height and 9 millimeter to the width. Another in the place where we have done the sinus lift. Initially we had 3 millimeters, then we have 9.5. And implant placement and final result. Case number 5. Take a look here. Here we've got 4 millimeter of the residual bone on the place of 16, sorry. Access to the sinus, collagen sponge. Another picture, and the implant bed. Sorry, no, it was not an implant bed, it was the sinus lift also. And you can see after half a year, we had 3 millimeters. Now we have about 12.3 millimeter bone. And the implant placement. Another, and the left side, we have 2.4 millimeter. You can see here the small dot of the is the rest of endodontic material. The access to the sinus. Sorry. And you can see here the Schneiderian membrane. The less, if we have the less bone residual bone we have, in fact, this technique is easier to perform, and we can, from time to time, we can see the saline solution. And you can see the CBCT scan after half a year. So now we have 10 millimeters of the bone. And the implant placement. This is the last case of our webinar. This is very strange case. This is a young lady. She's now about 30 years old. This case was done 3 years ago. She came to my office. She was during the orthodontic treatment. She has a milk tooth in the localization of tooth 3, and you can see the canine was stuck in the lateral wall of the nose, and the sinus is coming even into the first incisor. So after laryngological consultations, we decided to leave this canine inside because to avoid very harmful surgery. On the CBCT, we see that we see this canine, and we see that we have only 5.7 millimeter to the height. This is the milk tooth, and you see the braces. Unfortunately, we can see here the bone resorption, the defect of the bone. She did not agree for bone block augmentation. So this is the access to the sinus. After sinus lift, placing an implant. This is the implant 3.75 RSX, and here you can see the picture after the surgery. The place, a very popular place in Krakow, the Wisła river bank. A lot of Krakow citizens are going there with kids for the walk. Okay. Thank you. A message take home. So think about the biology and physiology of the bone healing always. Be as much as it is possible low invasive and traumatic. Always use proper substitute material to exact augmentation procedure. There are no bad biomaterials, they are only improper used. Always think about the blood supply of the graft. Use the size of graft has matter, and it also influence the technique which you will be used for the surgery. There is no blood supply to the graft from Schneiderian membrane, and Schneiderian membrane has only osteoclastic influence. Use only long-time resorbable membrane favorable bovine material. Mobility of the graft causes failure. Close operation field without tension, and in augmented area only use implants made from titanium grade 4 and with hot edge surface. Thank you very much for your attention. If you have any question, please.
Hello. So, dear Dr. Zitek, thank you very much for your very didactic presentation, the deep approach into the sinus lift approach with the piezo technique. Just before the questions are coming, and just before we start with the questions, I just put my presentation here. I just want to remind you on our next sessions on our Semados Campus special webinar series for professionals this Wednesday. So in 2 days, we're gonna have our next session, and the next session will be about CAD/CAM procedures. So CAD/CAM individual prosthetics with 3Shape and ExoCAD, and this will be with Mr. Stefan Kautz, a colleague here from BEGO Implant Systems. Next Tuesday at 11 a.m., so 1 hour later. So the the Central Europe time. We're going to have also a CAD/CAM session. Important points to keep in mind with Dr. Oriol Cantor from Barcelona. This will be he will bring lots of literatures and interesting cuts and clinical cases about the importance of using original components when we talk about CAD/CAM procedures. Then on the 4th of May, we're going to have the colleague from Croatia, Dr. Juraš Turkin. He will speak about implant prosthetic therapy, the plan from yesterday for tomorrow. And the last session program for this webinar series is with Dr. Eham Kajaluglu from Turkey, talking about digital approach in peri-implantary pink and white aesthetics, immediate, definitive, custom abutments. And also just to remind you, we have our education program in the second semester of 2020. Dr. Gerd Körner in Zagreb, Croatia, talking about periodontal downs to aesthetic hives on implant, and digital workflow with hands-on with Dr. Kleanthis Manolakis. This would be in our headquarters in Bremen in 11th of December. We also have the open days from BEGO Implant Systems. You can find the information in our webpage. The next meetings will be in November and December. Last but not least, to remind again of our campaign, Help Against Corona, We Care. So in our webpage, you can download for free, your dental technicians, some items, the production of protection goggles, masks, and also door openers, hand protection. So all of these free of charge, of course, and this can be everything package.
Hello, Marcio.
Yes.
Yes, connection has broke. Okay, I can hear you again.
Okay. So I give back to Dr. Tsitek. We have some first questions. The first one is, the smokers are contraindicated for sinus lift?
Mainly yes, because the smokers have sinusitis, and it is how we can say it. Yes, because of this. This is not the acute sinusitis, but the sinusitis lasts for years usually. So this is contraindication. We should consider it as a contraindication, same like for the implant placements. Smoking is contraindication. So in my clinic, usually I'm avoiding patients who are smoking. If they are smoking, I'm asking them to give up smoking at least for 3 months before the surgery.
Okay, thank you. How can you control the soundness, intactation of Schneiderian membrane from crestal approach? How can you determine the state of the Schneiderian membrane? So how can you see that it doesn't have any perforation in a lateral approach?
During the surgery, during elevation, from time to time, we have to close the patient nose and ask for blowing. So we have to do the Valsalva maneuver, and from this we know if we have a rupture or not. So it's completely predictable in this case, because if there will be a rupture, at once we will have the bubbles, because everything is fulfilled with the saline solution in the so the liquid, so we can see if there's a rupture or not. If the rupture occurs, then we have two possibilities. With a little bit of luck, we can try to close the rupture with the collagen sponge, and let's say in 60–70% of cases it works, and we can perform the surgery further. Or if it happens at the beginning of our surgery, and we cannot stop and we cannot close the rupture, then we can finish the surgery and postpone it into 4 weeks, because 4 weeks is a time when the Schneiderian membrane heals itself. Because this is very small surgery, usually we are closing it with 2-3 sutures. So patients after the surgery, they are not suffering any morbidity, any pain or swelling. So after 4 weeks, they are coming for the surgery without any problem, and I've noticed that they are even more relaxed in the second surgery than in the first time. So you can postpone the surgery in this case.
Thank you very much, Dr. Tsitek. I have one in Spanish. I'm gonna make here a translation. So, can you use tricalcium phosphate that have a bone natural, probably is autogenous bone? So tricalcium phosphate with natural bone is correct to use this?
Yes, you can use it. You can use it without any problem. The problem, I think there's a problem with the structure. The problem is only with the synthetic mixture between synthetic hydroxyapatite and beta TCP. Because if you use the hydroxyapatite, clear hydroxyapatite, it's working perfectly. If you use clear beta TCP, it works excellent. But if you mix both of them, it happens from time to time that there is inflammation. But of course, if you have a natural hydroxyapatite and you want to use it, it's okay. Because idea of creating a synthetic in this way was pretty smart, because hydroxyapatite is a scaffold for new bone formation, is a matrix, and the beta TCP gives a substrate for bone production, meaning the ions of calcium, of phosphorus, and the water. Everything was needed for bone formation. But if you mix them too, then it's a problem. But for with natural hydroxyapatite, probably it will be no problem. The problem is that the synthetic hydroxyapatite has a different structure, because if you take a closer look, for example, it doesn't matter if it's bovine bone, human bone, or synthetic bone. Everything is, from the chemical point of view, is the same, but you have a different time of resorption. So the structure is meaning. So I think with natural hydroxyapatite shouldn't be any problem.
Perfect. Thank you very much. Why piezo surgical devices have so many tips?
Why?
Yeah, that's an interesting question.
It depends how the development and research department is creating. It is creative. It depends
Yeah,
from this. But probably, I think the question was for Action's intralift technique. Probably this is the question for this. And I think because intralift was the first technique of access, crystal access to the sinus, and I think that's why they have so many tips. The second, what I've shown, it was my design, because and I've designed on my idea was to use only one tip for the surgery, and not to touch Schneiderian membrane, to be on the safe side. But you know, it's always easier to create something, to develop something, than to invent something. It's always easier.
thank you very much. Here only a thank you from Dr. Van den Kham. And thank you very much also from Dr. Fadi asking, is there a preferable type of graft when it's not applicable to have autograft bone, which has a better result to use during sinus elevation with crestal or lateral approach? So yeah, I think what we were discussing, you can say probably again. So alternatives for autologous bone.
For in sinus lift, I think the favorable material is the bovine material because of long time resorption. Of course, you can if you place the implants, you can put only collagen or nothing other to put into the sinus, and you will have a bone. But we have to ask what will happen after several years, after let's say 10 years. After 10 years, this bone will disappear because of the osteoclastic influence of the Schneiderian membrane. That's why I think it's better to use the bovine material because it's long-time resorbable material.
Okay, here's only a thank you from Dr. Kitilkaya from Turkey. I hope I said right your family name. And our question, other than surgery, can piezoelectric technique be used for periodontal treatment like root planning or debridement or a simple scaling?
Of course, of course. It can be used for this. I've only mentioned about the surgery, but for perio, of course, almost every producer of the piezoelectric device has in their portfolio of the tips for periodontal treatment. For scaling, also you can use it, but I wouldn't use this device for scaling because this device is very, very expensive, and it's cheaper is to use the conventional piezoelectric scaler which we have in our dental units. But of course you can use it for perio, for root planning, for cleaning the root, for curettage surgery. Every producer has in its portfolio the tips for these purposes.
Thank you very much. Which is the sequence of tips used for the technique, and which is the speed to elevate the membrane? Is it the speed for cutting cortical bone?
What do you mean the speed? It
The
depends.
velocity, yeah, the velocity of to elevate the membrane, yeah.
Exactly, because if you take a closer look for Action Satellite, then for the first 5 tips you are not elevating Schneiderian membrane at all. Then when you are using the trumpet, then you are elevating the Schneiderian membrane. In my idea, in this what we are developing with the Esachrome, then you elevating the Schneiderian membrane during passing the cortical layer of the sinus floor. So the time of the whole surgery is getting shorter, and in some cases I had a surgery which duration was around 20 minutes, including suturing after the surgery. 20 minutes for the sinus lift.
Okay, I will make an adaptation of the question of Dr. Vadiati, because yeah, asking in a case 1, why did you not, why you didn't use 8 millimeter implant instead of sinus lifting? So I make the question like, what do you think about short implants when you compare with sinus elevation? Probably I will do like this.
That's a very good question, because everyone is saying that the short implants are working, and I have to agree, they work. But after years of using them, I see that more short implants are gone than the long implants. So now I'm turning from the short implants to the conventional implants, and I prefer to do sinus lift.
Thank you very much.
Especially the problem. Sorry, one
No,
more
no,
thing. It
no
is
problem.
especially the problem with losing implants is more often with the patients who are grinding their teeth, and even if you use the crown coated with the composite to be more softer, even in those cases, I see that in some cases that I'm losing those implants. And then when I am in this place, I'm putting the longer implants, they last and nothing it happens. So short implants are okay, but in some years you have to be aware that you will lose them more often.
Thank you. Nice
That's
approach.
my experience. Of course,
Yeah.
you can agree with this or not. It's a matter of experience.
Hello from Greece. If you rupture the membrane and you use the collagen sponge to repair it, how you know that is okay and you can continue? So
Because
you
you
put
have
you can continue or postpone the surgery when you put the sponge.
because every time you have to try with the Valsalva maneuver. If the air is coming through the access hole, that you know that you did not close the rupture, and then you have to postpone the surgery. From my experience, I'm trying 3 times. One time if I have a rupture, which is very rare, then I'm putting collagen sponge, let's say 2-3 cubes. I'm trying. If it works, okay. Then if not, another time, and then the last time is the third time. After the third time, if I'm not able to close the rupture, I'm postponing the surgery.
Thank you very much. And
You can use also for this PRF. I am
it's the
not a fan of PRF. I'm not a fan of PRF, but for this purposes, it works perfectly also, and you can use the PRF instead of collagen sponge, even if you want,
which
of
was
course.
which was exactly the next question. Do you maybe use PRF to this procedure? So you just
You can use it, but you cannot use the PRF instead of particle material.
a friend of you is sending you, and thank you a lot for the presentation, is Dr. Nina Kuhakski, the
Oh,
director of our marketing department and product management department. Thank you, doctor. It was really amazing. Have a good job. A dental student, the colleague will be Dr. Jafari. And also here, thank you, Dr. Zitek, for the great presentation from Dr. Paula Ferreira, probably from Portugal. So this was the questions that we had here. Was a nice open discussion, I would say. So I will thank you again. Yeah, thank you for the moderation and great information also from Vihendra. There is one more. So what is your
mhm.
opinion for the NSK intralift system?
I did not try it, the NSK. I've heard that they've changed, they modified their device 2 years ago, I think. And the last time when I was working with NSK, it was 4 years ago, and I have to admit I was not satisfied. But from this, what I know from the specification of this device, it will not work as strong as those 3 devices which I have mentioned.
If I understood correctly, in your technique, you take off the membrane with the pressure of the saline liquid. Can you explain
Yes,
a little better? Yeah.
and vibrations are also very important. Usually, when I am conducting the courses in my clinic from piezo, there is one I'm always for the beginning. I am giving the exercise for the doctors. I'm giving them the fresh egg, and I'm asking them to take out the eggshell from the fresh egg with the piezo, because with those small tiny vibrations, the eggshell is coming out from the egg. In sinus, we have the same situation, but from the opposite. Then the soft tissue is steering from the hard tissue. So these 2 things are important. In the piezo hydrodynamic sinus lift, vibrations and the pressure. There are 2 important things. If we have only pressure, probably we will, of course, we will elevate Schneiderian membrane, but if we will have some, we will have a septum, or after chronic sinusitis, we have some that the Schneiderian membrane is stuck to the bone, then we can have a problem with elevating only through the pressure, and Schneiderian membrane will tear in those places. So both things are very important for elevating the Schneiderian membrane.
Okay, and we have a last one. Thank you very much. And you already told about it, Dr. Zitek, but again, for how long you postpone the surgery after you have a rupture of the Schneiderian membrane?
4 weeks. 4 weeks.
So I would like to thank you very much, my friend, for accepting our invitation.
Thank you very much, Marcio. Marcio, one more thing. Here you see my email and mobile. If you will ever have any question,
wait a second,
or you want to make a consultation with a case which you will have, feel free. You can try to
contact. You can put your screen. Yes, that's here. Okay.
You can send it to my mobile, to my email, or contact me through a mobile. I'm available on WhatsApp and Viber if you are calling from abroad, from EU. So feel free if you want. If you will want any course, just let me know.
Thank you very much. And just I want to salute a very nice friend from Iran. He's thanking us both. Dr. Zitek is Dr. Shaham. So thank you, friend Shaham, to be in the webinar today.
Thank you very much.
So I will finish the session as the moderation. Thank you all for the participants. Thank you, Dr. Zitek, and we see in the next session. Thank you very much.
Yes, thank you very much. Bye bye.
Bye bye.